So active movement testing. Generally speaking, I can ask 100 therapists why you do active movement testing, and the number one reason I'll give you, and it may be the only reason I give you, is because of it shows the patient's willingness to move. That's it. This is true, but there's a reason for knowing how willing they are to move, and that's generally about the pain level. You really can't just go and grab them and move them passively, because you don't know the reaction that's going to provoke. So watching them move actively will give you an idea of how much you can push on this. Also, active movement testing will show you the quality of motion, and in the only way that it can be shown, that's the patient moving. So you'll see deviations of movement, arcs, and other abnormalities in movement patterns. You can watch the scapula for scapular rhythm and all this stuff. You can only see that with active movements. It gives you a baseline for comparison between active and passive range of motion. You should have more passive range than active range. And if you're not seeing that, if the passive range is no better than the active range, the chances are that this is being volitionally guarded, because even spasm won't come on until you've actually pushed it a wee bit. This will also show you how scared they are of moving. So if you're not able to take them further into the range than the active range will show you, then they're generally holding back, or they know the pain's going to be severe, but they're frightened anyway. This will also give you a baseline for how the patient is progressing with treatment. Is it improving? Is it getting worse? Or is it plateauing? And all of this will either have you continue with the treatment, change it, or stop treatment entirely in some cases. So active movement has a lot of reasons for doing it. And probably the most important reason is you get a gut feeling for the patient and what they're complaining of just by watching them move. Okay, on to passive movement testing. This is where you're going to get most of your information about what's wrong with the patient, and the objective testing anyway. So you can do passive movements all the way through the range. You can take the shoulder, for example, from by the side and move it all the way through elevation if you want to. You'll get no more information from that than if you simply have them lift their arm up and then overpress at the end of range. So this is what I strongly suggest you do, otherwise you're likely to be exhausted by the end of the day from pulling people's limbs around. There's no point to it. Active movement, at the end of their active range, you've ascertained their range, the level of pain and so on. You can then overpress into the pain or into the range of your testing. Having said that, you overpress into each range you actively have them move into, which includes the painful ranges. Overpress into pain. I know you've probably been told not to do that, but if you think about it, this is about the dumbest thing that can be said to you. Why would you only test pain-free movements? You're interested in their painful movements, not their pain-free ranges. So either the people telling you this are spectacularly stupid, or they simply don't trust you not to be able to do this without damaging the patient. I do. We can let you manipulate people. We should be allowing you to test into pain. Now, passive range of motion testing for end feel is an exploration of the end of range. You don't go jumping in there, ripping at their arm or their leg and tearing it out of the socket and beating them over the head with the soggy end. This is done carefully and judiciously, and you're constantly feeling for what's happening under your hands when you're moving them. So overpress into pain. Otherwise you'll never feel spasm, because you only get that at the end of a painful range, and you'll never feel an MTM feel, which is probably the most important thing you can feel. So test them at the end of the active range for convenience, and then test them into all ranges. So that's how we do it. Now let's have a look at why we do it. First of all is range of motion, obviously. You've done the active range of motion. You're looking at overpressing into those ranges, and you're looking for a number of things with the range of motion, and you're comparing it with the active range. So you would expect with a movement that isn't a dysfunctional movement, doesn't produce pain or as a movement abnormalities, that the passive range will be larger than the active range. Now this is true 90% of the time. The other 1 or 2% of the time it's because of the bony configuration. So elbow extension, for example, in pronation anyway, will give you a bony end feel, and you're not going to get much more movement out of that than the active range gave you. Similarly, if you're looking at something like the SI jump, where there isn't a lot of movement to start with, the passive movement is a bit more than the active movement, although it's difficult to judge that, but it's not much of it. Now, in cases where the range of motion isn't that much larger from the active to the passive, it's tough to look at a range of motion for passive movement, and you end up doing what you do anyway, and that's concentrate on the end field, which I'll come to later on. So you're also looking at whether the range of motion increases after a painful range because of things like painful arcs. The patient may well stop moving rather than actually produce the arc by deviating or forcing his way through it. The patient may stop movement when the pain starts, but you can keep pushing through it, or you can move around the block, so you actually do the arc for them and then carry it on up through the range you were trying to test. So this speaks to things like painful arcs, bursal problems that you can shift around it a little bit by moving off of the bursar and then moving around it. So by doing a deviation of the movement, you can continue with the range you're testing and get real judgment for it, and it may well be full range of pain free. Pain. You expect to see more pain with overpressure than with active movement. You may see pain where there wasn't with the passive movement, that wasn't there with the active movement. All of that is logical and commonsensical, and this is usually about the patient stopping the movement when the pain is first felt or in anticipation of the pain being felt. None of this is unusual, but you've got to push into pain-free ranges to produce pain when the patient isn't doing it. So this is why you have to overpress into both pain-free and painful ranges. The end field we'll talk about a little bit more, and this is probably the major reason why you're doing passive movements. Also the pattern of restriction. Now, we can talk about this in the active range, but it's better spoken of in the passive range. Cyriax described this as an articular pattern or a partial articular pattern or a non-articular pattern. And this was the range of motion in most synovial joints when there's an inflammatory process going on will conform to an articular pattern of restriction. Now, I'm not sure that all of his were well thought out, or he was using the most obvious limitations. The big one here is the shoulder. Cyriax gave this as limitation of lateral rotation, abduction, then medial rotation, and he didn't speak to flexion or extension, and I'm not sure why he didn't do that, but that was left out. But the articular pattern for the shoulder is generally agreed that this is what it is. These are the big movements, these are the easiest ones to test, and these are the ones that show up the abnormality quickest. Now, this is for an inflamed joint. A partial articular pattern could be where you have scarring on part of the joint capsule. So if you damage a shoulder, if you dislocate your shoulder, for example, you may well get scarring on, say, the anterior aspect of the shoulder where it dislocated through, in which case you'll see lateral rotation restricted, but the other movements may not be that badly restricted. Because this is giving you a capsular end field, it becomes a partial articular pattern. Non-articular pattern is about things other than the capsule or inflammation inside the joint. And this would be ligament injuries, which are scarred down, and in our world now, which wasn't present with Cyriax, or at least not in his model, subluxations of the joint. So our subluxations that we manipulate and surgical subluxations and dislocate that we don't manipulate. So these would all consist of these non-articular patterns. Personally, I don't use these terms very much, and I don't seem to be much worse to wear for them. My feeling is that the ultimate aim of an examination is to make the diagnosis, not the thought processes going into that diagnosis on the way to it. So I generally don't worry about it, but you will come across these patterns of restrictions. You're also looking with a passive movement to provoke symptoms where the active movement doesn't. Other symptoms, paresthesias, neuropathic pain, dizziness, and so on. Stuff that is not painful as such, but it is other symptoms, neurological, neurophysiological, and visceral symptoms sometimes. So these are the reasons you do range overpressure into both pain-free and painful ranges. All right, end fills. First, end fills are basically the feeling that you get from the final limiter of the range of motion. So you can classify this as normal or abnormal. In fact, you have to classify it as normal or infill, or normal or abnormal. So a normal infill is what is felt pretty much by everybody in the population to different degrees. Somebody with very thick tissues that have been worked because they're an athlete, you're going to get a much harder infill when you're testing joints with a capsular infill in those than you will do in, say, a ballerina. But throughout the population, the quality of the infill remains much the same. If it should be capsular, it is capsular. If it should be bony, it is bony. Only the quantity of the infill can change from harder to softer from individual to individual. Secondly, infills that you normally feel are composite infills. These are normal infills. If you try and take the range of motion at a joint, the first barrier to that is the muscle, the tone of the muscle. So that's going to be your barrier, and when you push through that, so you have to push reasonably hard to get the proper infill. When you push through that, then you'll pick up the underlying infill of this, whether it's bony, say in elbow pronation, or capsular in shoulder, and so on. So it's a composite infill normally. Now, in abnormal infills, the abnormality generally comes to the surface, and you lose or you minimize the effect of muscle tone, especially in joints that are limited in range. So typically you can take the tone out by doing, if it's excessive tone, you can take that out by doing hold relax or putting more proprioception into the joint, but you reduce the muscle tone to the point where it doesn't really play a big role in you feeling the infill, but you'll still have a composite infill. Where the joint is dysfunctional, especially with limited range, that muscle doesn't really play a role. So composite infills are the norm with normal joints, but are a little unusual in dysfunctional joints. In fact, it's usually much easier to feel a dysfunctional infill, with the exception of hypermobility, but it's easier to feel a dysfunctional infill than it is to feel a normal infill. So it's important that you put enough force through this to get there. So, but I'm not going to talk about composite infill now. I'm not going to keep saying this is a musculo-ligamentous infill or so on. This is about, I'm going to leave that off and just call it capsular, soft tissue, and so on. Now, there are infills that are normal and infills that are abnormal, although the normal infills can become abnormal. So these include capsular infills, soft tissue infills, bony and muscular infills. Spasm, empty and pathomechanical infills are abnormal, always abnormal. So let's look at the capsular infill first. This is the feeling you get when you stretch the ligament or the joint that helps restrict movement. Now, the capsular infill abnormally can be hard or soft, but capsular infills are hard and soft within the same person. So if you're looking at, say, wrist flexion versus wrist extension, they will both give you a capsular infill. But wrist extension, which moves it into the close pack position, where the big ligaments and the thicker capsule become involved, is much harder than the infill for flexion. What we're looking at is whether or not the hardness of the infill for that joint and that movement is harder or softer than it should be. So it means it's absolutely vital that you start looking at both sides of the body. Now, I know you say you do this, but I've had numerous occasions where patients presented a case to me and said, okay, I'm finding this. And I say, what does the other side feel like? Oh, I never tested that. You can't do that. You cannot do that. You have to test both sides. Otherwise, you've got no comparison. So hard and soft capsular infills, both normal and abnormal. If you're finding a harder than it should be capsular infill, it means that the capsule ligaments have thickened, and this is part of arthrosis. or scarring on the capsule or the ligament. If it's too soft, it means that it's been overstretched or even torn in the case of capsule and ligament, and you're getting a softer infill. That is, the capsule is much thinner than it should be, and that's what you're picking up with this. I'll come back to what I said before. Sometimes you have to get rid of the overlying muscle tone. It could be hypertonus as a neurophysiological response to the pain, or it can be normal tone, but sometimes you have to get that tone out. Soft tissue into position, they talk about the elbow flexion and knee flexion both being soft tissue into position, but that is not true. If you test passive flexion of the knee, not with the hip, not in prone, but in supine, so you bend the knee and not stretch the quads, then you'll find that infill is completely different from that of the elbow. It's qualitatively different, which means they both can't be the same structure. In fact, elbow flexion, when you test it correctly and with care, it turns out to be a capsular infill and not soft tissue into position. That, of course, is not true if you get a bodybuilder who's got huge biceps muscles. But for the normal person, it is a capsular infill. Otherwise, I think soft tissue into position in non-obese, non-overdeveloped individuals, it's only found in the knee. Even ankle dorsiflexion will be a capsular infill if there's not a problem there. Now, generally speaking, though, there's often problems going on at the back of the ankle that will limit plantar flexion before the capsule does. So, bony infill. Elbow extension is about the only example that appears normally. So, and even then, only when you're testing elbow extension with full pronation added to the movement. Otherwise, if you do it in supination, you'll pick up a capsular infill. And you can prove this very easily. You simply do the test in full supination, then pronate, you'll get more movement, and then that stop at the end of it. This is a dead end. It's not like the jam joint you get with pathomechanical hypermobility, but it's a dead end. Now, that's normal for the elbow. If you find it elsewhere or too early in the range in elbow extension, then you're probably looking at osteophytosis of some form, but you've got abnormal bone blocking the movement at this point. Muscular infills. There are, if you try and do knee extension with hip flexion on, for example, you're going to get limited knee extension. The hamstrings will become tight, and that will limit you. You won't be able to get the end range for the knee joint. You've got to do that with the hamstrings on slack, so you can get that range of motion in there and feel the infill. In which case, it'll be a hard capsular infill. The ankle's another interesting case. If you do ankle dorsiflexion with the knee extended, you're going to find that it's normally a muscular infill. If you flex a knee, it'll become a capsular infill. And that's obviously because of the gastrocnemius going over the knee joint. Now, these are both examples of the constant length phenomena, where the range of motion is dependent on the position of another joint over which a common tissue runs. So you're looking at a muscular infill being inappropriate. You can also get the reverse of this. So if I'm using the ankle again, for example, if I test dorsiflexion with the knee flexed, with the knee extended, I expect to see a muscular infill. If on the other end I get a capsular infill, I should also be seeing a limited range of motion at the ankle. And this is where the capsule is so hypertrophic that it's limited movement before the gastrocnemius can block it itself. Also remember that muscular is always part of an infill. And as I say, this is about the compositeness of the infill. Spasm, this is the first real abnormal movement. If you find spasm, it's always abnormal. It doesn't matter where you test it or when you test it. If you're finding spasm, it's almost entirely related to the amount of pain the patient's suffering in an appropriate tissue that can provoke spasm. Either way, this is not good. You don't want to be producing spasm all the time because it's simply buggering up the joint every time you test it. So take that in place. And this isn't a matter of putting heat on it and getting the spasm down so you can do it again. This is a protective reactant for the joint. And it happens with fractures, inflammation, tumours, tears in the muscle will give you this as well. So this isn't a matter of trying to get rid of the spasm. You can get full range. The spasm is the full range of motion. An MTN fill is extremely rare, and you should always consider it, with one exception, as an indication of severe pathology. Now, to define an MTN fill, it's where you're going through the range of motion and the patient is trying to let you, so they're not guarding this and spasm isn't intervening. And you're taking the range in, the patient becoming more and more disturbed. The pain is getting worse. They're starting to sweat profusely. You're starting to sweat profusely, and the screams have driven everybody out of the waiting room. And you stop the test by yourself because of the amount. Now, this isn't being wussy about it. This isn't, oh, it hurts me, so I better stop. This is about you not being able to go further without both you and the patient, anybody in hearing distance, vomiting. This indicates severe pathology. The exception to that is, and this is very rare, I've never seen this in the US or Canada, here in England, but nowhere elsewhere, is an acute subdeltoid bursitis. These are very characteristics. They come on extremely quickly in hours. So you go from a normal range of motion in the shoulder joint to almost no movement at all. Any movement that moves the arm away from the side is impossible for the patient. You can move it passively into medial lateral rotation, but that's it. Every other movement is severely painful with an MTN fill. These get better in about 10 days if you treat them. They get better in about a week and a half. But these need resting. Really do need resting. And finally, pathomechanical hypomobilities. These are typically found on the pathomechanical exam, but this is a jammed joint, and we've spoken about these when we talked about pathomechanical problems. But this is simply a jam at the end of the joint. This is a lively feeling, other than in contrast to the bony end fill. So these are your end fills. These are what you take notice of. Now, I'll give you an example why goniometry doesn't work terribly well. If you look at my elbows, you can see that I've got more movement on this side than this side. Sorry, the other way around. I'm mirrored here. So this side, this side has less movement than this side. Not a lot, but enough. Now, is it possible to measure the difference? And the answer really is no. I think there's maybe 5 degrees of difference between these two. Your goniometric error is 5 degrees, so you can't measure the difference, but you can see the difference. The question is, which one is dysfunctional? The one with too much movement or the one with not enough movement? And do we know which is which? So you're left with the end fill. Not necessarily, it may not even be painful, but you're left with feeling this. Which one doesn't feel normal at the end of range? And this is the value of end fills over goniometry. To summarise, active, passive, resisted testing. Between these three types of testing, you should be able to get a good idea of the state of the musculoskeletal tissue, that is the muscles, tendons, bones, joints, the hard parts of the musculoskeletal tissue, not the neurological side, not the vascular or the visceral side. These may come out as a consequence of test results, but they won't be directly tested by this. So it's the musculoskeletal system in of itself. So the active tests are there to look at the level of pain. You can get more from the active movement test, watching the patient, than you probably can from the subjective exam. Simply by looking at, so the patient may say this is an 8, this is a 3. They may say this is severe, this is mild. But if you watch them move, the hesitancy of the movement, the look on their face, the anxiety, and so on, and of course the range of motion, will all give you a better idea of how painful this actually is to them. This is possibly as close to objective testing of pain as you're going to get. So this plays a huge role in it. Willingness to move, which comes up as an answer every time you ask a question, why are you doing it, is a very small part of it. They may be willing, they may be unwilling. And a severe fracture may be willing to move, but may not be able to, whereas a minor problem with somebody who's very fearful, they may be unwilling to move to the point where it doesn't move. So it really doesn't test willingness, or you won't get much information if you think of it in those terms. So you're looking at the quality of movement with active movement that you can't get anywhere else, painful arcs, deviations and so on. And you're going to use the range of movement actively and the onset of pain with the range of movement passively and the onset of pain to see how much of a discrepancy there is between the two. You're also going to use the active range to assess progress in this patient, probably more so than passive movement. If you see a major jump in the active range, you know you've done a lot for the pain. And the patient is most certainly going to use active movements as their gauge as to whether or not you're improving them. So you can talk about the end feel all you like to the patient, but if they're not moving more, as far as they're concerned, they're not improving. Passive movements are mostly about end feel. So we talked about normal versus abnormal, abnormal being quantitatively or qualitatively different to what the end feel should be in that person. So that really does mean testing both sides. Absolutely, the same with tenderness palpation. You have to test both sides. And although this should be obvious, I often get people who describe a patient to me, all of the stuff they found on the examination, I'll say, what was the other side like? They say, well, I didn't test that. You can't do that. You just can't do that. You have to test both sides so you can compare the two. The end fields, the normal end fields are going to be different from person to person to some degree. Big, bulky athletes are going to have much harder capsular end fields than will a ballerina, say. So a lot of this is about training, but it's also about body type and size. So the end fields that are always abnormal were spasm, empty end fields, and pathomechanical hypomobility end fields. These are always abnormal, and whether or not it's significant is a whole different issue. Then the last testing which we did first was contractile testing, palpation, stretching, and isometric resistance. Now, I talked about tendonitis versus tendinosis, inflammatory conditions, contractile conditions versus non-inflammatory degenerative type contractile tissue lesions, and they're miles apart. So what Cyriax said about contractile testing was active movements in one direction, that is the direction that's being pulled into by the troubled tissue, will be painful, and passive movements away, which stretches that tissue, will be positive. And that's true of tendonitis. In fact, all movements may be painful, whether you're doing the stretching movement actively or passively. Tendinosis, it's nowhere near that reliable and that black and white. It just isn't. So with some degeneration, degenerative conditions of the tendon, it may be that stretching is painful, in some it's actually contraction. So what my suggestion is, you definitely palpate. Do that first. If that whole contractile unit is not saying that there isn't a contractile lesion in there, I think that's reasonable if you're palpating properly. But once you start testing, I would test the resisted test from the stretched position. If I'm doing wrist flexion rather, I would resist flexion from the fully stretched position, because now the tendon is being stressed by, tendon and muscle are being stressed by stretching and then contraction. If that's negative, the chances are it's going to be negative when you do it in the neutral position. But with a tendinosis, that may be negative in all positions of contraction. So stretching is your next go-to. So I would say that for a positive contractile test, you must have palpation positive. Once that's positive, you need either the stretch to be positive, the contraction to be positive, or both of them to be positive. But 2 out of 3 of those things, provided one of them is palpation, is probably enough for you to say this is a contractile tissue. Now, you may have trouble identifying which tissue this is. A lot of muscles do the same movement. So then it's going to be down to palpation, which you need to do anyway, because if you're going to treat these, you have to know exactly what area you're going to be treating with whatever treatment you're going to be using. So That's it. These are the mainstay of the musculoskeletal exam.